Today I am presenting a case of asthma exacerbation. Chief concern, asthma. History of present illness. This is a 10-year-old male brought in by his mother for increased cough, wheezing, and shortness of breath over the past week. Mother has noted no fever or loss of appetite, but has decreased his physical activity. He's currently completing amoxicillin treatment for right ear infection. He's taking Montelukast daily, but has not been using his inhalers until 2 days ago. He stopped them months ago. Review of systems. Constitutional. No fever, normal appetite, decreased activity. Eyes, no itchiness, discharge, swelling or redness. Ears, nose, mouth, and throat. Runny nose and ear pain. Able to smell, no sneezing, sore throat, or phlegm in throat. Respiratory, cough and trouble breathing, wheezing. Cardiovascular, no chest pain or tightness, no palpitations. Gastrointestinal, no abdominal pain, no nausea, no vomiting, no diarrhea, and has good appetite. Medications. He is currently taking amoxicillin 500 milligrams cap 3 times a day. Cetirizine 10 milligrams PO daily. Montelukast 5 milligrams PO daily. ProAir HFA 90 micrograms per actuation aerosol inhaler, 2 puffs Q 4 to 6 hours PRN for cough, wheezing, or shortness of breath. QVAR, Redihaler, 80 micrograms per actuation HFA breath activated aerosol, 2 puffs twice a day for asthma control. These 2 inhalers, he had not been using them for months ago. Past medical history, seasonal allergies, hay fever. Allergy tests were done in 2009. Asthma was diagnosed in 2008. ATV accident in May of 2017. Recurrent ear infections since September of 2017. Past surgical history, tonsillectomy with adenoidectomy in June of 2013, tympanostomy tubes June of 2008. Family medical history, maternal grandmother with asthma and sister with eczema. Social history, lives at home with parents and 2 younger siblings. No smokers in the home. They have a pet. They have 1 dog, indoor and outdoor. He comes indoor and outdoors. Child participates in physical activities. Breathing problems with activities. No mold exposure in home. School performance is poor. Objective. Vital signs. Temperature 97.7 Fahrenheit. Height 4 feet 8 inches. He's in the 49th percentile. Weight 104.2 pounds in the 92 percentile. BMI 23.4, 96 percentile. Blood pressure 100 and over 78 to his right arm in a sitting position. Systolic blood pressure 87 percentile. Diastolic is in the 93rd percentile. Heart rate 84. O2 saturation 96% on room air at rest. Physical exam. Constitutional. General appearance normal, alert, pleasant, no distress. Head, face, on closing mouth able to breathe through nose without difficulty. Nose, pale, swollen turbinates right and left, and normal nasal sounds. No nasal discharge. Eyes, conjunctiva, no hyperemia or discharge. Ears, external auditory canal, normal, no wax, tympanic membranes, normal color, and landmarks. Oral cavity, moist mucosa, tonsils surgically absent, oropharynx, no postnasal drip, positive cobblestoning. Neck, no cervical adenopathy on anterior or posterior chains. Chest wall, no intercostal or subcostal retractions, no barrel chest, no tenderness on palpation. Lungs, auscultation, normal respiratory effort, no wheezing or crackles, coarse breath sounds, no cough, voice normal. Cardiovascular, normal palpation of heart, PMI non-displaced, auscultation of heart, regular rate and rhythm, no murmur or rub. Gastrointestinal, abdomen flat, normal bowel sounds, no hepatosplenomegaly, and non-tender. Assessment and differential diagnosis. Diagnosis number 1, asthma, mild persistent with acute exacerbation, J 45.31. This is an established problem worsening, non-adhering with rescue or steroid inhalers until 2 days ago. Manifested by reported wheezing, increasing cough and shortness of breath, and decreased physical activity, but no fever or loss of appetite, and coarse breath sounds on exam. No retractions or wheezing. Normal cardiovascular exam. Differential diagnosis number 2, allergic rhinitis, J30.9 unspecified. This is another established problem. He's stable. Runny nose and ear pain referred with exam demonstrating pale, swollen turbinates bilaterally and oropharynx with cobblestoning. May benefit from addition of nasal steroid spray to decrease nasal turbinate swelling. Differential diagnosis number 3, right otalgia, H92.01. Eustachian tube dysfunction, no physical findings of otitis media or otitis externa on exam, suggesting refer ear pain from swollen eustachian tubes and swollen nasal turbinates. Plan, pharmacological medications. Diagnosis number 1, asthma, Montelukast 5 milligrams chewable tablet, 1 PO daily. Pro Air HFA 90 micrograms per actuation, aerosol inhaler, 2 puffs Q 4 to 6 hours as needed for cough, wheezing, or shortness of breath. Q-VAR Redihaler 80 micrograms per actuation, HFA, breath activated. 2 puffs twice a day on schedule for asthma control. For diagnosis number 2, allergic rhinitis, cetirizine 10 milligrams tablet 1 PO daily. Consider adding nasal steroid inhaler like fluticasone propionate 50 microgram per actuation, 1 to 2 actuations in each nostril daily. Diagnosis number 3, right otalgia, Tylenol tablet 325 milligrams PO Q4 to 6 hours PRN for pain. Plan non-pharmacological. Implement asthma guidelines from American Academy of Pediatrics. Address decreasing environmental allergen exposure to dust and pets. Address non-adherence to rescue and steroid inhalers to decrease risk frequency of asthma exacerbations. Hand mother and patient a copy of their asthma action plan and communicate with the school and the school nurse. Re-instruct patient and mother on proper inhaler device technique and have child demonstrate back to me the proper technique. Follow up at 2-week intervals until asthma is well controlled, then Q3 to 6 months. Debriefing. I could improve the management of this child's nasal allergies by adding a steroid nasal inhaler to decrease nasal turbinate swelling and oropharyngeal cobblestoning, as well as eustachian tube dysfunction and ear pain in this patient. Fluticasone propionate 50 micrograms per actuation, 1 to 2 actuations daily would help achieve this. Thank you.